Welcome to another edition of the Understanding Sports and Exercise Medicine Research Show, the show that brings you the latest research straight from the horse's mouth. I'm your host, Tim Travail from Torrens University in Melbourne, and I'm here to support clinicians and early career researchers in the journey through the complex world of health-related research and ultimately help us to deliver high value and effective care for the people we work with. Alright, today it's good to be back with another episode after a few weeks. I'd originally planned to do about one a month to keep it manageable for me, and after putting out about 5 episodes in 6 weeks or so, I needed to slow it down a bit and make some way for some other things, and particularly keep my own research progressing. So I appreciate you sticking with it, and I hope this episode makes up for the wait. Today, we're fortunate to be joined by up-and-coming researcher Dr. Melanie Plinsinga. I've been interested in her work for a few years now, as it's had a direct impact on some of the underpinnings of my own research, so I'm particularly happy to be having this conversation with her. Melanie has produced some excellent work as part of her PhD, as well as recently in her postdoctoral research capacity that we dive right into today. As always, if you enjoy this episode and you get a moment to share or to rate the podcast on iTunes, I really appreciate it. It goes a long way to help with the algorithms, so more people get to see it and really keeps me inspired to keep going with the podcast. So without further ado, let's get into it. Today, I'm pleased to be joined by postdoctoral research fellow from the University of Queensland, Dr. Melanie Plinsinga. Melanie is a human movement scientist with a special interest in chronic health conditions and pain. Having completed her undergraduate and master's degrees in the Netherlands, she went on to complete her PhD at the University of Queensland, where she investigated the multidimensional nature of hip pain. So Melanie, welcome to the podcast.
Thank you very much, Tim. Thank you for the invite. Very pleased to be here.
Excellent. All right. So before we get into the main paper that we're going to be discussing, your latest research, cross-sectional research, can you just tell the listeners a little bit more about yourself, your background, and how you got to studying the research area you are now?
Yeah, of course. So as you said, my background is in human movement sciences. So I completed a bachelor and a master in that area. And during my master's, I kind of became interested in musculoskeletal injuries, in particular tendinopathies and persistent pain that people have with tendinopathies. So during my master's, I kind of did a little bit of research in that area, and I'm particularly interested, I guess, in the psychosocial side and sensitivity to pain and touch in people that have persistent pain. So that's why I did my PhD at the University of Queensland, looking at the multidimensional nature of people that have gluteal tendinopathy or greater trochanteric pain syndrome. And yeah, that's what we're going to talk about today, about my, I guess, my main PhD paper, my PhD baby. Yeah.
Okay. And so let's just talk about this systematic review then to start with. So we just mentioned off there that we were going to be just setting the scene really with the main findings here from a systematic review, and then how you got to the cross-sectional work you're doing now. So the systematic review for the listeners is titled Physical Findings Differ Between Individuals with Greater Trochanteric Pain Syndrome and Healthy Controls, a systematic review with meta-analysis. And your co-authors from the University of Queensland there also. Bill was Bill your primary supervisor through your PhD?
Yeah, that's correct. Yeah.
Okay. And so do you want to talk to us a little bit about why, so you mentioned your interest in this area, but why did you decide that there was a need for a systematic review to start with?
Yeah, that's a really good question. So when we first started, we knew that GTPS is very prevalent, especially amongst females, middle-aged females. And it has a high incidence rate as well. But we actually, when I started, there wasn't that much research on the patient characteristics of this population. So we do know from other conditions musculoskeletal injuries like tendinopathies and OA, that people with persistent pain, they have certain patient characteristics. So we see associations with, for example, high fear of movement, anxiety, depression, but also sensitivity to pain. And this research wasn't really out there when we started for GTPS. And I think this was the reason to first start with a systematic review to identify exactly what we knew and what was out there, what literature was already published, and where the gaps were. So what do we know? What do we need to know? And yeah, what research needs to be done to, I guess, ultimately improve the management for people with persistent pain in GTPS. So that was the reason, I guess, we're doing this systematic review.
Yeah, that makes a lot of sense. And going into it, did you expect that you were going to be doing a meta-analysis as part of it, or was that something you sort of you developed as you went through it, as you sort of went through the study?
I guess we knew that we were going to do it if there was enough out there to be able to do a meta-analysis. But to be very honest with you, I thought maybe we weren't able to do it. But eventually we were able to do it for some outcome measures, not all of them. But yeah, when we started with it, it just depended because for a meta-analysis, you need 2 or more studies for a certain outcome, right? And because there was not a lot out there, we just weren't sure if we were able to do that.
And I'm sure it's going to be very familiar for most of our audience, but just the terminology of GTPS, or Greater Trochanteric Pain Syndrome, it's fairly new. I mean, it's been in the literature for a little while, but it's certainly rising in popularity, you know, between clinicians and the amount that it's used. So do you mind just touching on a little bit of that background, where it sort of come from, what other clinicians or other people working in sports and exercise medicine might know about it as a condition?
Yeah, sure. So Greater Trochanteric Pain Syndrome, so GTPS, is more an umbrella term, I guess, for a lateral hip pain. And there are different pathologies, I guess, that can cause this lateral hip pain. So pain and tenderness around the greater trochanter. And most of the time it's due to gluteal tendinopathy. But the reason we use the term GTPS is because, as in my research, we only clinically diagnosed people with lateral hip pain or GTPS. And there is a little bit of I guess people have different opinions about this, but if you want to diagnose gluteal tendinopathy as a tendinopathy, you could argue that you need a clinical and an imaging diagnosis for this. So I guess that's the reason why we mostly use GTPS, but with the assumption that the underlying pathology is gluteal tendinopathy.
Yeah, great. I think that's just an important sort of background and precursor for the rest of the discussion.
Yeah.
So let's go into the main results of your systematic review, as we don't want to spend too much time on this because we're going to be getting right into the cross-sectional study. But we'll just go down onto what's this page, sort of bottom of page 4 of your systematic review. Do you mind just taking us through then your main findings here?
Yeah, sure. So I guess the main findings so there were 13 studies published from only 5 different research groups. So I have to say that a lot of the studies were published by the same groups, which is not a bad thing, but it just shows you that there was not a lot out there at that time. So the main findings, so here you can see the standardized mean differences in patients. So on the right side, you can see the things that favors GTPS, and on the left side that favors controls. So what we did is we show you the pooled outcomes, pooled effect sizes where we could, and where we could not, we just showed you the standardized mean differences based on the data of those papers. So here you can see from the meta-analysis that people with GTPS had a higher BMI and also a greater a larger graded trochanteric width. So that's from the meta-analysis. And then from the single studies, you could also see that they had a larger hip circumference and a larger inter-ACIS width. So that's a larger iliac width. So I guess what I'm saying is that the anthropometric features of people with GTPS were significantly different to the ones to the controls.
Fantastic. Okay. And then you also did some work around the actual muscular findings as well, didn't you? Strength finding.
Yeah. So we had a look at the strength that was reported in different papers. So what we found was that there was, from the meta-analysis, we saw that people with GTPS had less strength in the abductors compared to controls, which I guess is well known by everyone, but that was on the affected leg mainly. And on all the others, there were actually no differences between GTPS and controls. So it was mainly abductor strength.
Yep. Okay. And we often hear about external rotators and external rotation strength with this population, but you didn't find such a difference with the external rotators, did you?
No, we did not. But if you have a look at the graph, you can see that the one paper, so Gannerton, they did show a difference, but this was based on a very small sample.
Yep.
And another study did not show a difference, so the Ferron study. Yep. These are just 2 studies. So I'm a big believer of replication studies. It's not very sexy, but I think it's needed because you cannot base a conclusion on 2 studies. So yeah, it's hard to conclude.
As you say, not very sexy and sometimes not easy to get published, but very important.
Yeah.
We're looking at population sizes with sort of groups of 8 and 10 in each side of the arms here. So yeah, it's certainly important. Okay. Anything else you wanted to touch on this systematic review, Melanie, before we move on?
I think the main point of the systematic review that I guess we wanted to bring across is that we saw these differences in anthropometrics, muscle strength, muscle activity, and kinematics and kinetics. And yeah, feel free to read the paper and send me a message if the listeners do have questions about that. But I guess another main finding was what we did not find, and that was we did not find any literature or evidence on psychosocial factors or sensitivity to pain or touch, which we know from other tendinopathies and other musculoskeletal injuries, that is something that usually is different between people with persistent pain and healthy controls. So this was, I guess, something for us that we thought, okay, this is what we need to investigate during my PhD then.
Yeah. Excellent. All right, let's just pull up the next paper. Okay, so here's the main paper that we're going to talk about today. So just for the listeners, the paper is it's out now, is it, Mel, in Pain Medicine?
Yes, yeah. I believe it is, yeah.
So it's titled "Individuals with Persistent Greater Trochanteric Pain Syndrome Exhibit Impaired Pain Modulation as well as Poorer Physical and Psychological Health Compared with Pain-Free Individuals, a Cross-Sectional Study." So a nice descriptive title. And is this with the same authors, this paper?
Almost, yeah. Almost. So my 2 supervisors, Brooke and Bill, Brooke Coombs and Bill Vicentino, and my colleague Rebecca Meller as well.
Okay, and so we've obviously, I think we've covered the background context in how you got to sort of the interest of this area, but specifically then, why did you decide there was a need for this cross-sectional work or cross-sectional methodology to be done?
Yeah, that's a good question. So we wanted to look at patient characteristics and if people with persistent pain present with certain characteristics. So the way we thought we best answer this question is with comparing people that have persistent pain and people that do not, which is a cross-sectional design. The limitations with the cross-sectional design, so if you look at the hierarchy, the level of evidence, cross-sectional studies are pretty low, I guess, in the hierarchy. But another way you could approach this is that it could be a starting point of research. So we didn't know a lot yet, and this is where we decided to start. And I guess after we discuss this paper, where we have to go next, but the next step will be to go, I guess, up the chain and go to longitudinal studies and prognostic studies and things like that.
Okay, and so let's get into the. I think we've talked a little bit about GTPS, which you cover well in your introduction here. Now, I wanted to just talk probably about the primary aims of the study for a moment. So, just want to take us through your primary aims and your hypothesis.
Yeah, sure. So our primary aim was, as you can see, to look at the differences, so to quantify the differences in physical, sensory, psychosocial outcome measures between people with GTPS and pain-free controls. So we really wanted to look at from a multidimensional perspective, so not only physical, not only psychosocial, but capture all of them. But then in addition to that, we also wanted to have a look if factors that were certain factors that were associated with pain and disability in GTPS. So are there certain factors from these multidimensional factors that are associated with pain and disability within only this GTPS group? And I guess what we hypothesize is that, based on the current literature in other tendinopathies, is that there would be impaired physical strength and function, mechanical hyperalgesia, so this means being more sensitive to mechanical pain, and psychological distress in GTPS compared to controls.
Okay, and the study design, we've talked about it being cross-sectional, so we've got a snapshot in time, and the participants, did you recruit these participants specifically for this study, or were they part of a wider or another study that you're working on?
So these participants I recruited only for this study.
Okay.
Yeah, the recruitment.
Tell us about that sort of criteria that you went through for the inclusion criteria there.
Yeah, so the inclusion criteria that we handled was, I think one of the most important one was they had to experience lateral hip pain, obviously, but their pain intensity had to be at least a 2 out of 10. And it had to be for a duration of 3 or more months. So we really wanted to capture those participants that had persistent pain. So it had to be 3 months or more. And the diagnostic criteria that we had for GTPS was pain on palpation and reproduction of trochanteric pain on at least one of the clinical tests. And this was based on a paper that was published recently. And I think those were the main criteria. Then we actually excluded participants that had other pains that were more significant than their hip pain. And I think this criteria, we had to exclude a lot of people based on this, which was a shame, and that might be something that I would be doing differently if I could do it over.
Okay, we'll definitely come back to that, but no, that one. So it was mainly where the hip pain, people had sort of concurrent hip pain along with the lateral hip pain. Was that that was the biggest issue? Was it?
Yeah, and the reason for that, I guess, is because we were doing quantitative sensory testing, and we really wanted the local hip pain, and we wanted to make sure that the remote sites were remote and that we did not have any referred pain or other pain sites that could interfere with that. So that was the reason behind it. But the practicalities of that were a bit, it was hard to recruit.
Yeah. And I noticed your the 11-point NRS scale was a 2 out of 10, or equal or greater than 2 out of 10. That seemed a bit lower than some of the other papers I've sort of read around that. Some of them say either 3 or 4. Was there any sort of reason or rationale as to why you picked the 2 out of 10? Was it to try and sort of gather a larger pool of people, or is that what you've seen in the literature that other people have used?
I agree. Usually they use, I think, 3 out of 10.
Yeah.
I think we started with that when we were talking about or setting up the study. But we wanted to make sure we capture also the people that have persistent pain that is maybe a little bit milder, but still persistent for long periods of time. And if they had ticked all the boxes for all the other inclusion criteria, we didn't want the pain intensity to be the one that excluded them if it was persistent, and at least a 2.
Yeah.
So that's the reason. Yeah. So I guess we wanted to capture the whole range.
Yeah, that makes sense. Okay. And in terms of, let's go down and into sort of pain and disability. So what were you looking at there in the pain and disability? What were you particularly wanting to look at?
Yeah, so the pain and disability, we used average pain, worst pain, pain duration during the last pain during activity, in the last week.
Yeah.
And for pain and disability, we use the VISA-G. So that is a measure of, I guess, pain and functional disability or ability, you can say. That's ranging from 0 to 100. So we used this and we measured this also for a secondary aim to see if there were any factors that were associated with pain and disability in this population. So for the sensory testing, I guess what we decided that we would assess the most painful spots of the patients and a standardized spot on the hip for controls and a remote site to measure the quantitative sensory testing on. And we decided to measure, we did not measure the whole, so we used the ROLC protocol that most listeners will probably be familiar with, but we decided to pick some of the tests and not all of them based on the literature that's out there in tendinopathies. And the decision for that was, first of all, because of the literature, and second of all, because we had a huge battery of tests. So eventually we measured cold pain thresholds, heat pain thresholds, and pressure pain thresholds, and temporal summation and condition pain modulation for this study.
And just out of interest, how long did each participant, how long were they with you for to go through all of this testing?
Yeah, so the first participant was probably with me for 3.5 hours, but at the end that was pretty quick. So I think on average about 2.5 hours for the whole battery of tests. So this was QST, strength measures, and all the other functional and physical measures.
Yeah.
Yeah, so it's quite a while.
Quite a commitment for them. You've got some very friendly people coming in and helping you out there. That's good to see. Yeah. All right, let's touch on the strength measures then. So, assuming you've do you want to touch on the strength and physical measures that you looked at?
Yeah, so we decided, and this was also, I guess, based on the literature, that we would measure hip abductor and extensor strength. And we did that with a handheld dynamometer. Now you can see in the photographs how we did it. So that was that. And then we also decided to measure a range of, I guess, functional measures. So we measured the 20-meter walk test, the flight of stairs, and the balance test. And I guess the reason that we wanted to do this is because we wanted to have a look at their functional ability to do flight of stairs, walking, and balance. And there wasn't much literature out there either. So we had all those measures in there as well.
Mm. And had you, I'm just trying to remember back to the systematic review then, had you looked at hip extensor strength in your systematic review?
No, so hip extensor strength, I think wasn't in there. Yeah, the reason that we added it is because we thought that it is an important muscle to measure as well for this particular population. But it wasn't done yet at that time, I think, or at least not published. So yeah, but we can discuss that at the results.
Yeah.
Those
Okay.
outcomes.
And did you find these the setups that we can see in the images here? So just the listeners can hear. So you've got the Lafayette manual muscle tester, and you're using patients in a sort of supine for the abduction testing, to take out some gravity, and then you've got the extension in a sideline position, again with straps around the manual muscle tester. Did you find these to be sort of fairly reliable positions?
Yeah, so we played around with these a lot. I have to say, I found it pretty hard to find a position that would be reliable for all different sizes of people. Because you can see here my colleague that's pretty tiny. And but then the measurements that we did, usually it's middle-aged females. Sometimes a bit bigger, and I found that that was quite challenging. But that was challenging for every position that we tried in the beginning. So I think the more we practiced, the better it got, and the straps definitely helped to standardize it. It wasn't always, not every participant, I think, loved the straps, but I think those made it much more reliable.
Okay. Had some other, so we talked about, so you've got some other self-reported outcome measures here as well. Do you want to take us through those ones?
Yeah, so the self-reported outcome measures that we assessed were, first of all, quality of life, and then a range of psychological outcome measures, so pain catastrophizing, anxiety and depression, fear of movement. So yeah, those were the ones, the patient reported outcome measures that we assessed in these groups. So some of the psychological outcome measures we only assessed in the patient group, because those measurements were related to pain. So we couldn't do all of the testing on both groups, which was a little bit of a limitation of this.
Okay, and then you were going to do some sort of correlations there between sort of pain intensity, number of pain regions. Did you were you including people that had more than one pain region, or were you were just narrowing it down to people who only had that lateral hip pain?
Yeah, so lateral hip pain had to be the primary pain of in the body, but there were some people that also had a few other pains or other pain sites, but they were always less in intensity and duration than the lateral hip pain. So we thought it would be very beneficial for the readers to just have a look at if there were any associations between pain intensity and number of pain regions and the outcome measures that we assessed.
Okay. All right. And so that takes us through, I think, the methodology there. And so you've touched on perhaps one or two things, but before we go on to results, in hindsight, was there anything that you would change about that methodology if you were going to repeat the study?
Yeah, I've thought about that in the last couple of days. I mean, there's always things that you would do differently, but I think for me, in regards to the recruitment and the people and our eligibility criteria, I would probably also include, so we got a lot of people that had lateral hip pain, but also other pain, so that were either as significant or more painful than the lateral hip pain. And I think from a clinical perspective, so if you want to implement your findings or translate it to clinical practice, I think it's very important that it reflects the people that are coming to clinical practice or to the clinic. So I think we really were very selective in the people that we recruited, and we did that because we wanted it to be standardized. But because of this, we also excluded a lot of people that had GTPS and also other pains. And I think this group is very interesting, especially from a perspective of maybe psychosocial factors or sensitivity to pain. So if I could do it over again, I would probably include another group with people that have persistent pain and other pain sites that are as bad or even worse in intensity. Yeah.
Okay. There's always going to be room for hindsight, I'm sure, in every study we do. So
Yeah,
that's good to hear those reflections.
we can do a whole podcast on that.
All right, let's go on to the results then. So, do you want to talk about the let's get into the results overall. But first of all, we'll just go through, because you mentioned you've got a nice image of the actual groups, so the GTPS groups and the control groups here, which just shows that recruitment process with some really nice specific detail of why we've got exclusions through different stages in the survey, in the telephone screen, and then at the physical screening stage. And sort of shows you where you started with, from 535 down to sort of 40 or so, and you can really see the specificity you've talked about, and perhaps why so many have been removed from the original people completing the surveys.
Yeah, I think it's quite self-explanatory, but I think it's interesting to see that we started, so for the GTPS group, we started with 535 people and we ended up with 40 participants. So this is just a thing that everyone goes through in research, I guess. But there were a lot of people that we excluded, and one of the main reasons was, as we already touched on, that hip was not their predominant pain, and with that I mean that they had other pains that were worse when they filled out the survey or when we called them the standardized mean differences. So just to quickly tell you why we did it like this. So we really wanted to show the reader that the differences between GTPS and controls, but as everyone know, a p-value doesn't really give you that much. So we also wanted to make sure that you could see the direction and the magnitude of effect between the groups. And standardized mean differences or effect sizes are a great way to do this and visualize it. So that's what you're seeing right here. So for the quantitative sensory testing, what we found is that pressure pain threshold, so PPT, on the hip was significantly different in GTPS and controls. And this was very large effect size on the hip, so that was the most painful side. So it makes a lot of sense because we tested the most painful side. But we also found this in the PPT on the elbow, so on a remote site where there was no pain. So this was quite an interesting finding. We saw a slight difference and small difference in cold pain threshold on the hip. But there were no differences in heat pain thresholds or temporal summation.
Mm-hmm.
Then for the condition pain modulation, which is the last one that you see in the graph, we did see a difference. So we looked at the absolute condition pain modulation, which is something that I have to just note, I think. And we saw a significant difference in, so the difference in PPT before and after the immersion of the hand in a cold water bucket.
Mm-hmm.
Yeah, so, and that was a moderate effect.
Yeah. Okay. All right, let's have a look then. So, anything else? Anything else you want to cover on that, or is it easier to stay on this graph as we go through some of the other areas, just looking at the results, or did you want to go back up to the specific sections? What's easiest?
Yeah, I think with the graph, it might be, yeah, it would be the
Yeah.
easiest.
Okay. And so, should we have a look at? Should we just talk through the strength and physical measures then?
Yeah. So for the strength measure, so hip abductor strength and extensor strength were both, so people with GTPS were weaker, I guess, than the controls, and they both had moderate effect sizes. And this was the same for the balance test, the 20-meter walk test, the sit to stand test, and the flight of stairs. So all the strength and functional measures were impaired in GTPS compared to controls with a moderate effect size. And then for physical activity, it was a little bit different. So we used the Active Australia survey for this, and you can see a difference, and it's just for total physical activity. It was just significantly different, but not for figures physical activity. Now I do have to note that the Active Australia survey, sometimes it's over-reporting or under-reporting is a thing. So I find it personally very hard to measure physical activity myself. So yeah, if anyone has tips for me on how to best measure that, then
We might need to talk after
okay.
the podcast now, because it's sort of specifically what I'm trying to figure out as part of my PhD work is that how we sort of measure that physical activity and then the association with sort of pain levels in people in these population groups. So watch this space. We've got something
Okay,
hopefully coming out of that, but
that'd be great to know.
it's a long way off. All right, so just let's just go back to the listeners. I talked about before. We really want to make sure that if someone's having a look at this and we can understand what we're seeing in this chart. So if we just take a look at something like the 20-meter walk test, and we can see here that we are in favouring of the GTPS rather than favouring of the controls. Whereas when we look at something like hip abductor torque, we see it in we see the measurements off to the side of favouring controls. Do you mind just going into the basics of how to read this chart when we're having a look at something like hip abduction strength versus the sit to stand test, for example?
Definitely. Yeah, so this is a tricky one, and I guess to read the graph, you really need to know what the test measures. Otherwise, you wouldn't really be able to read it properly. When you have a look at hip abductor torque, so it favors the controls, which means that the controls have a higher value compared to the GTPS. In this case, with hip abductor torque, it means that they are stronger than the GTPS group. But when you look at, was it the sit to stand test that we were discussing?
Yes, anything that's on the right hand side.
Yeah. On the right hand side. If you look at that, we measured that in seconds. So when it favors GTPS, it means that the seconds for the GTPS participants that it took for them to finish this test was higher compared to the controls, which means they were slower in completing this test compared to controls. So I guess it's really important to know how you measure the test to be able to read the graph.
And I think that's something that I mean, just intuitively, if you're not used to reading this type of research, you pick up something like this, and you're thinking, right, everything on the right hand side of this graph should make me think, right, this is associated or this is down with someone with this condition. But we don't like to make it easy for people to read, do we?
Oh no, I try to make it difficult for everyone. No, yeah,
No,
that's
that
right.
wasn't
Like
you
it's not.
personally. Researchers in general.
Yeah, no, it's not that with favors. Yeah, I guess we don't mean that that's a good side or the bad side. Yeah, it just means the values, I guess, in the way you measure it.
Yeah, absolutely. Okay. Well, thank you for explaining that. It's going to be helpful for people picking that up. All right. So, Let's go on to the self-reported psychological distress and quality of life measures, if we can.
Yeah. So anxiety and depression, those were two that were higher levels in GTPS compared to controls with small to moderate effect sizes. Now, I do have to note, and this is also written in our paper, that so we classified them in anxiety or depression cases based on the hats that we measured it with. And the anxiety cases in the GTPS group were, from the top of my head, I think 25%. But the depression cases in the GTPS and the control group were both 5% or lower. So even though there was a significant difference between the group, the cases of depression in both groups were very, very low. So you just need to have to put this into context, I think.
Yep.
And yeah, quality of life was one that really blew my mind. So quality of life index was significantly higher in the controls compared to the GTPS, so lower quality of life in GTPS, and health status, which is another measure of the EQ5D, was also lower in GTPS compared to control. So I think health related quality of life was the one that had the biggest effect size out of all the measures that we did. It shows you what a big of an impact this can have on people's life.
Yeah, I think that's perhaps an under researched or under considered finding from this type of paper. I think that's really important for us to consider and to when we're working with this types of population. So but yeah, very important. Now, okay, anything I think we've gone through most of the findings there. Have we gone through anthropometrics yet? I think we cover that at the start.
No, we skipped that.
We might have skipped that one. So just talk just a little bit about what you found there with those anthropometrics.
Yeah, so what we measured was body mass in the index, waist girth, and hip circumference. So all of those measures were so those measures were higher in GTPS compared to controls with a moderate effect size. And I think this just kind of confirms what we already knew, and that's already out there in the literature as well, is that usually these people are a little bit bigger, have a larger body mass index, waist girth, and hip circumference. But this is something that we wanted to measure and just, I guess, confirm and add to the body of evidence there.
But largely in line with what you'd already found from the systematic review and previous research, yeah.
Yeah, exactly.
Yeah. Okay. All right. Now, anything else in terms of the results? I think that quite conclusively goes through the findings there.
Yeah, I guess the last thing that that we did was to have a look at that association with all these factors that we measured that you can see here on the graph, and pain and disability.
Yep.
So we did that with a linear regression model, and what we found was quite interesting, because we found that 26% of the VISA-G, so which measures pain and disability, was explained by depression, hip abductor strength, and time to complete stairs. And I think this is more, it was a secondary aim, but I think it really shows you that with a measure like VISA-G, which is really pain and disability, and when you see the VISA-G, it's all functional disability questions, still 26% of the variance in that outcome measure was explained by depression, abductor strength, and time to complete stairs. So I think that just really nicely shows you that it's not just physical, not just psychosocial, but it's a combination that contributes to pain and disability.
Okay, fantastic. And in terms of then of clinical practice, for people working with this types of population groups, so we've got the results and we've talked a little bit about the limitations of cross-sectional studies, but what do you see the value and the purpose, or what should clinicians be taking out of this paper, do you think?
Yeah, that's a good one. I think what you can take away from this paper is the evidence. And as you said before, this is just one time point that we measured this on, but the evidence that people that have lateral hip pain, GTPS, for a prolonged period of time, they do present with different patient characteristics than people that do not have persistent pain.
Mm-hmm.
And when you see people in clinic, this is something you, I think, need to be aware of. And you don't have to necessarily do something with it straight away, because I think that there needs to be a lot more research in GTPS out there before we can actually tell people, okay, this is what you need to do. But you need to be aware of it, that some people might need a different type of management than other people if they present with certain characteristics.
Yeah. And let's flip that to the person who might be experiencing this type of complaint. So if someone's listening when they've got GTPS, what would you want that person to know about your research and how it can potentially help them?
Yeah, so if you do have GTPS, I think it is important to work on strengthening. But that's not particular for this paper, I think, but something that is well known. And I think it's also important to know that if you have persistent pain, that you should educate yourself and know that it's not always one thing that causes it, and that there are a lot of things that contribute to persistent pain, and there are a lot of different ways to manage it. And I think that this paper shows that there is a lot of different things that need to be considered. And so, yeah, I would say educate yourself if you do have persistent pain or GTPS. And yeah, search for a good clinician to help you in that process.
Absolutely. And I liked what we were just sort of talking about before in terms of the actual the levels of health-related quality of life that might be impacted by people with this condition. So if you are struggling with it, you're not on your own. It's something that many people have some quite significant challenges with. So yeah, getting to a good clinician who can understand these types of influences that are impacting on you, and measure and assess those properly, and then get you onto the road to recovery. So
definitely, yeah.
So thank you very much. Was there anything else on this paper? Otherwise, I'd just like to ask what's next for you and what you're going to now.
Yeah, it's still a little bit of a, I still have a lot of things that I can analyze and publish, I think, for my PhD. So yeah, we have a few more papers in the pipeline that hopefully come out sometime soon. And yeah, I just hope to continue my research in looking at persistent pain and the management of it. And yeah, hopefully there will be a future in that for me and for all the patients that struggle with it, I guess.
Yeah. Well, I've really enjoyed this discussion today, Melanie. It's good to get into some of the detail of your paper. And if people want to, I'll put some of your details in the show notes, but just let people know where they can follow your research. Is Twitter the best place for you?
Yeah, so Twitter or LinkedIn, I guess, are the two best ways to contact me. And yeah, if anyone has any questions about this paper in particular or any of my other papers, feel free to send me a message. Always happy to discuss. Yep.
Okay, fantastic. Thanks very much, Mel.
Yeah, thanks very much for the invite. It was a pleasure.